speaking. Can you hear me well?
Yes.
Yes.
Okay,
Yes,
welcome.
Yes.
Welcome in the lecture about the functional neuroanatomy again, because this is our topic for today. So we will continue the topic of sensory pathways. I hope you may see the slides. And again, you don't need me, you need the slides. Okay, can you see the slides? Please tell me that.
Yes, I can see.
Very good. Very good then. Okay, so we will continue the topic on the sensory pathways, because if you remember from last lecture, the head region, which is supplied by cranial nerves in terms of somatic sensation, also serves as the site of receiving the stimulation, which is other than somatic. Okay, so in the head region, unlike in any other region, we have some highly specialized regions containing very specific receptors that react on special information and special stimulation. This is what we call the special senses. And actually these are sight, which is the vision. Then we have the hearing or audition, sense of head position and movements, which is the equilibrium, taste, which is also known as gustation, and smell, which is called olfaction. And this is actually the program of today's lecture. We will talk about the visual system and the visual pathway, the auditory pathway, vestibular, gustatory, and olfactory pathway. So today we start with the visual pathway, which is very nice for the students and for everyone actually, so it is good to know it. First of all, we should say about the receptors. As in every highly specific sensory pathway, we have very specific receptors, and these receptors are located in the eyeballs. Actually, one of the layers of the eyeball, called the retina, which is, as you remember probably from one of last lectures, which is the extension of the central nervous system, just like the optic nerve. So the retina is a membrane composed of neurons. And in fact, if you go to histology department, they will tell you that retina is composed of 10 different layers. You may see them here, like pigmented cells, like rods and cones, which are the most important for us for today, and some other lining layers. We are not histologists, so we do not require from you the knowledge of all these layers of retina in order, but please remember that the rods and cones are the most important here, but also some other layers like the ganglionic layer, for example, or nerve fiber layer, and so on. So first of all, we should say that the visual pathway starts in the receptor which reacts on the stimulation from the visual stimulus, and these are rods and cones, right? And the visual cortex, it runs to the visual cortex, and the visual cortex is near the calcarine sulcus and adjacent parts of cuneus and lingual gyrus. So in fact, the visual pathway runs from the eyeball toward the occipital lobe. Everything starts in the cones and rods. If you remember, these are modified neurons that are sensitive to light. And actually, rods and cones, they constitute the primary neuron of the visual pathway. Then they communicate with another layer of retina, with bipolar cells of retina, which constitute a secondary neuron of this pathway. Then we have a tertiary neuron, which is made up with the ganglionic layer of retina, and these are also modified neurons. So cones, rods, bipolar cells, and ganglion cells are all the modified neurons of retina. And then the ganglionic cells of retina, they send out fibers which run toward the brain. And these fibers will actually form the optic nerve. So first, 3 neurons are located inside the retina. This is why sometimes we apply a term of the intraretinal pathway for this run from the first to the third neuron. What happens then? When the information leaves the retina with the optic nerve, it enters the skull through the optic canal, if you remember, with the optic nerve, and then decussates, makes a junction with the contralateral optic nerve, and this is what we call the optic chiasma. Very nice structure to see at the base of the brain. Then the optic chiasma sends out symmetric optic tract. So we have right and left optic tract that runs along the hypothalamus to reach the body of the quaternary neuron. So we have 4 distinct neurons here, and the quaternary neuron is located in the thalamic lateral geniculate body. We do not have to add this thalamic because everyone knows there is lateral geniculate body, and we just say thalamic so that you know where it is, but the name is lateral geniculate body. So the lateral geniculate body, as you may see, forms a subcortical visual center, and it sends out some axons which form the optic radiation. The fibers of the lateral geniculate body form optic radiation that enters the visual cortex. This is the whole course of the visual pathway. Please remember that the optic chiasma is the site where the visual pathway decussates, so it changes the site. However, not all the fibers decussate in the midline, only half of them. This is why here you can see a partial crossing here, and sometimes neurobiologically the optic chiasma is known as the hemichiasma, simply because only half of the fibers are crossed and half of the fibers are not. So if we would like to explain the phenomenon of the visual pathway graphically, we should look at an object or a landscape, right? So this is the visual field. This is what we see when we look at something, right? On the right side we have something different. On the left side we have another object. So if they differ, we can apply some, let's say, colors, right? So that the left side of our visual field is different from the right side. Now, these sides of the visual field are reflected in the retina of the eyeball, so that the right side projects on the lateral aspect of the retina in right eye. We call it temporal part of retina or lateral part, and the lateral or the left side of the visual field projects to the nasal part of the retina. So we have the inversion of the picture that we see in the retina, so that the fibers which are on the medial part of retina look at the lateral part of the visual field, and the fibers which are in the temporal part or lateral look at the medial aspect, and the same for the second retina because they are the same. So each retina has 2 areas, temporal area and nasal area. And in the right side we have nasal area and temporal area, and please note that they register different parts of the visual field. Now, both parts which register the right side of the visual field send out fibers to the left-sided cortex, visual cortex, and the same for the remaining fibers from the nasal part and temporal part of the right and left retinas. As you may see, the fibers which cross are only the fibers from nasal parts of both retinas, while the fibers from temporal parts do not cross. This is why the optic chiasma is sometimes use this term for that it is the partial chiasma only, that only half of the fibers cross. So this is the level of the optic chiasma. As you may see, all the fibers that register the same part of the visual field, they run to the same part of the cortex on one side or on the other. So in fact, what the brain sees is the normal visual field, because the information in the cortex is analyzed by the brain and reverted within the brain. But the registration is, as you see here, right? The right side of the visual field in the left hemisphere and the left side of the visual field in the right hemisphere, and then we have it reverted so that both eyes see the same. Now, to be really detailed and specific, we should say that in fact there is no like two parts of nasal retinas, but in fact there are quadrants. So each retina is divided into 4 distinct quadrants, and what is more, there is a peripheral portion and the central portion, which is also divided into quadrants. And these quadrants send out specific fibers that, if you would like to make a map of these fibers in the lateral geniculate body, you would have, as you may see, the representation of different fibers in different parts of the geniculate body. And then, finally, in the primary cortex, you would also have specific representation of these fibers within the gyri adjacent to the calcarine sulcus. So in fact, this pathway is very, very topographic. So there is a specific representation for each, even the smallest part of the visual field, which is reflected or registered in the retina. Now, we should say that the damage of the visual pathway will cause very specific deficit in the visual field. This is why, if you know anatomy, you may predict what happens, right? Because if you know the deficit, and actually this is something that patients always say when they visit their doctors, so if you know the deficit, you may think about the location or the site of destruction, okay? Simply because we know the anatomical course of this pathway. So let's start with 3 very specific sites of the lesion, right? In case there is a damage in the optic nerve, like in here, we cut one of the optic nerves. As you may see, what is being cut or blocked is the transmission from the nasal part of right retina and the temporal part of right retina. So these fibers are blocked, okay? So actually this information does not reach the cortical center, okay? So in fact, one eye cannot see anything because nothing can be transmitted from retina. So this is what we call a blindness of one eye. In this case, this is right eye, okay? So the result of this is very simple. If you cut the nerve or you cut the retina or something happens to the eyeball or to the optic nerve, but still before the level of the chiasma, then it will result in the blindness of right eye. Now, another level, if you may have, or you can imagine, a damage at the midline, in the midline, in the optic chiasma, at the level of chiasma, that something is located exactly in the midline. So it does not affect the lateral part of the chiasma, only the medial bundles that cross in the midline. Then what is being cut and what is being actually blocked is the transmission from both nasal parts of both retina. So the result for the patient will be that the patient cannot see what is registered by the nasal part of retina. So what is the visual field deficit in here? this is what the patient cannot see actually, right? And this is what we call the heteronymous hemianopia or bitemporal hemianopia, because in fact the nasal part of both retinae, they actually see lateral parts, temporal parts of the visual field. So the patient cannot see if you cut lateral part of the visual field. The patient may see only the center of an image or of the picture that he looks at. Now, if the lesion is located distal to the optic chiasma and it affects the optic tract, right? Because this is the optic tract, then the geniculate body would be somewhere here, optic radiation and the cortex. Okay, so if we cut anything which is distal to the optic chiasma, we cut the transmission from the homonymous parts of retina because it is nasal part on one side and the temporal part on the other side. So in fact, the result will be the homonymous hemianopia. In this case, it is left-sided hemianopia. So the patient cannot see the part of the image which is located on his left side. So please remember these three cases. One case is proximal to the chiasma, the other case is in the midline of the chiasma, and the third case is distal to the optic chiasma because they constitute very anatomical diagnosis. So if the patient says that he or she cannot see the lateral parts and only the center of the picture, then you may think that something happens about the level of the chiasma, right? When the patient says that he cannot see the left side of the visual field, for example, these patients see only what is on the right side of the visual field. So if you think about it, you may think that the lesion may be distal to optic chiasma, and this is very, very important. Okay, we need to skip to another pathway because we still have 4 to do. So I think it would be okay if you know all of this about the visual pathway. And now let's proceed with the second one. We have auditory pathway, which starts in another region of the head, and this region is the vestibulocochlear organ. Vestibulocochlear organ is something which is located in the inner ear, very deep inside the temporal bone. As you may see, the inner ear contains the vestibule, which is one part, and the second part is the cochlea. And now we are talking about the cochlea, which has specific shape, like a shell of the cochlea. And then it has also the cochlear duct inside. So how is the sound wave transmitted to the cochlear duct? Simply, it enters through the external ear to the middle ear, is transmitted by the tympanic membrane here, and the chain of auditory ossicles. So the vibrations of sound waves are transmitted by the malleus, incus, and stapes, and as you may see, the base of stapes transmits the vibration of the sound wave into the system of perilymph. The perilymph is the fluid which is located in the inner ear. Now the cochlear duct is filled with another type of fluid. We call it endolymph. And this endolymph is seen in the cochlea itself. As you may see, the cochlear duct has a basilar membrane at the base of, and this basilar membrane contains the nerve endings, which we call hairy cells, because these are, again, modified neurons, which contain some it looks like hair actually, and these are free nerve endings that run to the body of these neurons, and these bodies form the spiral ganglion or the cochlear ganglion. And this is what we call the spiral ganglion of Corti. So this is the actual receptor of the auditory pathway. Now, let's have a look at the course of the auditory pathway. We run from the receptor to the auditory cortex. So the receptor is the hair cells of cochlea, in brief, and then the auditory cortex is where? Do you remember which region of the brain it is?
Is it the temporal?
The temporal lobe is okay, and more specifically?
It's the transverse gyrus of Heschel.
Okay, transverse temporal gyri, that's okay for me. So we have transverse temporal gyri, and this is our course from the hair cells of cochlea to the transverse temporal gyri. Okay, now the primary neuron, as I said, is the spiral ganglion, and it sends out the hair cells. So the hair cells transmit the information to the spiral ganglion. Then the stimulation runs within the branches of the cochlear nerve, and they form the cochlear nerve, and the cochlear nerve meets another nerve from the vestibule, and they form together what we call vestibulocochlear nerve. So if you look at the cochlea, this is the cochlea, you can see that at different levels we have the maxillar membrane with the spiral ganglion of Corti, and every single level reacts on different tones. So this information enters the spiral ganglion, and with the branches of the cochlear nerve, they form together, all these fibers, they form together what we call the cochlear nerve. And in the neighborhood, we have a vestibule and we have vestibular nerve. So as they are very close to each other, they unite and form the 8th cranial nerve, vestibulocochlear nerve. Vestibulocochlear nerve runs within the canal in the temporal bone, so it leaves the temporal bone through the internal acoustic meatus and enter the brainstem. So the vestibulocochlear nerve meets the secondary neuron, which are the cochlear nuclei. Cochlear nuclei are located in the brainstem. So we may say that the vestibulocochlear nerve ends within the cochlear nerve, and here we have synaptic junction between the first and the second neuron. Now, cochlear nuclei form the auditory stria. So this is the continuation of the secondary neuron, auditory stria. And the auditory stria, they form the trapezoid body, another structure of the internal organization of the brainstem. Trapezoid body and the lateral lemniscus is a band of fibers that actually end the secondary neuron. Now, the lateral lemniscus ascends up because we need to reach the transverse temporal gyri somehow, but we still have 2 other neurons. But before we go to the tertiary and quaternary neuron, let's have a look graphically how it is. This is the midline, as you may see, and we have the primary neuron first. So the sound wave enters the cochlea, then it is transmitted to the spiral ganglion, which is here. Here are the hairy cells of cochlea. Then the sound information enters the neuron, then it is transmitted to the secondary neuron. Here we have the vestibulocochlear nerve and the cochlear nuclei in the brainstem, and the cochlear nuclei send out auditory stria. So these are the bands of neurons, which may be medial, intermediate, and lateral, right? So here we are, and as you may see, some of the fibers change the side and enters the contralateral side, and some of the fibers still stay at the same side of the beginning, right? And they will meet the tertiary neuron, and they will make a synaptic junction with the bodies of tertiary neuron. So where are the tertiary neuron? As you may see, the tertiary neuron are at different sites. They may be in the nucleus of inferior colliculus, They may be in so-called nuclei of lateral lemniscus, superior olivary nucleus, or the nucleus of trapezoid body. Now, all of these neurons, they send out fibers that form the trapezoid body and lateral lemniscus again on the other side, and they actually enter the brachium of inferior colliculus. So now we are at the level of the midbrain, because inferior colliculus is the part of the midbrain. So the brachium of inferior colliculus leaves the the tertiary neuron enters to the brachium of inferior colliculus and meets the quaternary neuron, which is located in the medial geniculate body. So now the medial geniculate body is the subcortical center for hearing. And the medial geniculate body is the beginning of the quaternary neuron. And this neuron sends out axons forming the acoustic radiation within the temporal lobe, and the radiation enters the transverse temporal gyri. So this is the end of the auditory pathway. Now let's have a look in here. We have the bodies of the tertiary neuron. For example, in the nucleus of trapezoid body, the nucleus of inferior colliculus, or the nucleus of lateral lemniscus. As you may see, some of them change the side again, or reverse, and all meet the quaternary neuron. So we have the third synaptic junction with the medial geniculate body in the thalamus, and then with acoustic radiation the information reaches the cortex. So as you may see, this pathway is different than others because we have multiple decussations. One decussation at the level of the secondary neuron, another decussation at the same level. At the level of the tertiary neuron, we have another decussation and one more, so that we may say that this fiber, here you can see the auditory acoustic radiation from the medial geniculate body to the transverse gyri of Heschl. Okay, so here again we enter the brainstem, ascend up to the midbrain, and from the midbrain we go to the cortex. So we should say that taking into account the multiple partial decussation of auditory pathway, the unilateral destruction above the level of the cochlear nuclei will not cause so evident hearing loss as it was with the visual pathway, because visual pathway was simple. You cut the optic nerve, you don't see. Here, if we have the damage somewhere above the level of the cochlear nuclei, because still, if you cut the vestibulocochlear nerve, there is no transmission from one ear, and then you have deafness of one ear, right? This is obvious. If you cut the nerve, there is deafness of one-sided ear. But if the damage is somewhere above, then the information may still come from the contralateral side. So, in fact, we should say that these multiple partial decussations will not cause any evident hearing loss. Please remember that, because the diagnosis of hearing problems is not so simple and not so straightforward as it was with the visual pathway. Okay, we are very close to the vestibule, so we take this vestibular pathway again. Now, where is the vestibular system receptors? Where are they located? They are located in the second part of the inner ear, which is the vestibule. The vestibule contains some enlargements. These enlargements are called the saccule and utricule, which respond to the pull of gravity and to internal movement caused by linear acceleration. This is extremely important, linear acceleration. Now, the ampulla of semicircular ducts will respond to rotation of the head. So here we have linear acceleration or deceleration, and the ampulla of semicircular ducts will respond to rotational movements. So if you look at the at the scheme again, we leave the cochlea now and we look at the vestibule, which is the second part. As you may see, it contains some semicircular ducts. We have anterior semicircular duct, posterior semicircular duct, and lateral semicircular duct. So here we have this weird organization, but this is what we have. They represent three planes, more or less. And we also have the utricule, which is the enlargement of the vestibule, and the saccule, small pouches of the vestibule. Now, the utricule and saccule, then they contain the receptor zone. And again, we have the hair cells here, which are modified neurons again. And these hair cells, they touch to otolytic membrane in case of the utricule, right? So this is the sensitive zone which responds to the internal movement or the linear acceleration in case of the utricule. And in case of the ampular crests, which are located within the, here you have the ampulla of the semicircular ducts. The ampullae are also the enlargement. Here is one ampulla, this is the other ampulla, and the third ampulla is here. So you can see the duct, and it enlarges close to the main body of the vestibule. So these are the ampullae, and in the ampullae we have the zones which are known as ampular crests or crista ampullaris. And again, we have hair cells here, and these zones are covered with a structure which is called a cupula. Cupula is a covering that responds to the rotation. So the vestibular pathway runs from these all receptors to vestibular cortex. Now, why don't we know something? I will tell you in a moment. So the receptors are the hair cells of utricule, saccule, and semicircular ducts, and the vestibular cortex, where it is, probably one of the areas is in the inferior part of postcentral gyrus. This is what we already know. Now, we have the primary neuron, which is actually located in the vestibular ganglion. Vestibular ganglion sends out branches of vestibular nerve. This is something that you know. Then we have the main trunk of vestibular nerve, where it reaches the cochlear nerve, and they together form vestibulocochlear, the 8th cranial nerve. Then they enter vestibular nuclei, located in the lateral aspect of the brainstem. So, from now, there are multiple pathways that reach the cortex. So, in fact, we know that there is a connection. One of the connections runs through the thalamic ventral posterior inferior nucleus, but we don't know which neuron is that, whether there are any other areas on their way, or there is a straight connection. So we don't know whether it's the tertiary or quaternary neuron, but we know that as you may see, the vestibular nuclei, which form an accumulation of areas located in the lateral aspect of the rhomboid fossa, because this is rhomboid fossa. There are 4 vestibular nuclei: superior, lateral, inferior, and medial, as you may see. And here we also have the cochlear nuclei, very close, because the vestibulocochlear nerve enters this region. So this is where we are. As you may see, there are multiple connections to the spinal cord, to the medial longitudinal fasciculus, to the abducent nucleus, because it's important to relate the balance of the body, or the equilibrium of the body, with conjugate movements of eyes. So there must be some connections with the trochlear nucleus, with the oculomotor nucleus. They are represented by the fibers of the medial longitudinal fasciculus, and then for sure some of the fibers enter the thalamus, so that we don't know whether it's the 3rd neuron or maybe the 4th neuron of the ventral posterior inferior nucleus, and then they enter the cortex. If you remember the 2nd lecture of the CNS, I told you that there exist multiple different areas which are responsible for vestibular activity. So we know that at least some of them have different functions. There may be or more, let's say, descending, because balance is not only the sensation of the position of the body, but it is also a feedback to muscles. In case you fall, then some muscles will protect you against falling down, right? Now, this information has to be registered and received. This is what we have here, ascending pathways. As you may see, they are rather located close to inferior portion of the postcentral gyrus. But there are some other also. And we don't actually know how many fibers run to which specific area. This must be distributed by the thalamus. So please remember that vestibular pathway is another topic to be investigated in the human brain again. We should say that the unilateral damage of vestibular pathway at the peripheral level will cause transient vestibular syndromes. We call them vertigo, which is a dizziness, the lack of balance, the oscillation of eyeballs. This is what we call the nystagmus, very specific for vestibular pathway problems, and also nausea and vomiting, which are something disagreeable related to the damage of vestibular pathway. Now, bilateral destruction may cause similar syndromes, but of more persistent type. Okay, there is one more element of this pathway. It's a doll's eyes phenomenon. I said to you that the vestibular pathway is related to conjugate movement of eyes, and actually the vestibulo-ocular reflex, uncomplicated by the voluntary eye movements, is the topic in here, because the lack of conjugate movements of the eyeballs in the opposite direction to the movement of the head is called the doll's eyes phenomenon. And this is something very important to remember, because together with the loss of caloric reflexes, this may contribute to a diagnosis of brainstem death. So the doll's eyes phenomenon is one of the examinations which are performed in order to confirm the death of the brainstem, right? So in case there is no conjugate movement of eyes in the opposite direction, you may find that, I think with no problem, the movie in the YouTube in which you may see this. So this is something very, very important, and this is due to the damage of the brainstem, okay? Because this pathway runs through the brainstem. Okay, now we talk about something more nice, maybe. Gustatory pathway is quite far from the brainstem. However, it also runs through the nuclei, which are located in the brainstem. Here, the receptors of the gustatory pathway is located in the tongue and palate and the mucosa of the oral cavity, and these are actually the taste buds. Taste buds are, again, modified neurons which are located mostly in the tongue, and they send the information to the gustatory cortex. Gustatory cortex is located in the frontoparietal operculum. So the primary neuron actually composes of different cranial nerves, because the tongue is innervated by the facial nerve, and here we have geniculate ganglion, by the glossopharyngeal nerve for the posterior part, and vagus is also the nerve that forms the primary neuron. So the branches of facial, glossopharyngeal, and vagus transmit the information to the body of the primary neuron, and then with the roots of facial, glossopharyngeal, and vagus, they enter the brainstem. So the information from the tongue runs with different cranial nerves, and they reach the brainstem, where is the secondary neuron. The secondary neuron is located in the superior part of solitary nucleus. Solitary nucleus has two parts. The superior part is known as gustatory nucleus. So because the function is the sense of a taste analysis. So the fibers of the solitary nucleus run along the medial lemniscus. This is something that you probably know from last lecture. Medial lemniscus was related to deep sensation pathway. Now, if there are any crossings, we don't know exactly, but we know that the fibers reach the ventral posteromedial nucleus, VPM nucleus in the thalamus, and then with the sensory radiation they enter the frontoparietal operculum. So in fact this must be a pathway which is related to sensory pathways. They are packed very closely one by one in the brainstem. So this is why we don't know whether there are multiple crossings or there is no crossing. Now, what happens in case of destruction? We know that the unilateral destruction of gustatory pathway will cause abolition of taste sensation. We call it ageusia from one half of the tongue. So in case there is a damage of one of these nerves, we probably have the lack of taste sensation in the half of the tongue. Now, in case of more central damage, which is above the level of the solitary nucleus, the evident deficit of taste is not observed. This is why we think that probably there are multiple crossings at different levels, just like it was in the hearing auditory pathway. And the last but not least for today is the olfactory pathway. So we talk about the smell sense. And this is something up to date because you know that the lack of olfaction may be one of the symptoms of COVID disease. So we should know the anatomical course of this pathway from the receptor, which is located in the nasal cavity. And here we have the specific cells of the nasal or olfactory epithelium. As you may see, they are located in the epithelium, and the dendrites, they react on the odorants, the molecules of the odorants that enter this specific region of the nasal cavity. So it runs from the receptor to olfactory cortex, and the receptor is located within the olfactory epithelium. This epithelium, again, is composed of the dendrites of modified neurons that transmit the information toward the CNS. And the olfactory cortex is located in the uncus and adjacent parts of the cortex, which is called the entorhinal cortex. So here we have the primary neuron, and the olfactory receptor cells send out some dendrites to olfactory epithelium, right? So the dendrites are the first stage in the transmission to olfactory receptor cells, and they produce axons that are known as olfactory nerves, which form the first cranial nerve. Now, the olfactory nerves, they enter the anterior cranial fossa through the small foramina within the cribriform plate of the ethmoid bone. So they run through the skull base, through the cribriform plate, and they enter the olfactory bulb. And this is where we are in the secondary neuron, the olfactory bulb, and the mitral cells within the olfactory bulb. The mitral cells send out axons that form the olfactory tract. This is something that you can see with a naked eye at the base of the frontal lobe. And then the olfactory tract ends with the region which is known as olfactory trigon, and this olfactory trigon sends out olfactory striae. So the striae are again the bands of fibers that reach the uncus. Now, please remember that olfactory pathway is totally different from all the pathway that the sensory pathways that you already know, simply because it does not cross. Now, it does not run through the thalamus. And finally, it has only 2 neurons. So this is very, very specific pathway. Now, I said to you that the olfactory tract does not cross. This may not be entirely true, but if we have the olfactory epithelium somewhere here, then the olfactory nerves enter the olfactory bulb. From here, we have different types of fibers. Now, some of these fibers with the lateral olfactory stria, they enter the uncus, where the cortical centers for olfaction are located. But we also have some other stria, like intermediate stria. They run rather to the entorhinal cortex, which is a little bit further from the medial aspect of the uncus. And there is one more band, which is a medial stria that crosses the midline with the fibers of anterior commissure, and it enters the amygdaloid body. And this is the phenomenon of relation of the olfactory system with the limbic system, simply because the odors are analyzed within the limbic system, so that the brain, or the amygdaloid body, in fact, categorizes the odors as something being pleasant or unpleasant. Okay, so it is not only the reception of the information, but also the analysis. And this analysis is probably conducted in the contralateral limbic system. Now, we should say that the olfactory symptoms may be caused by a fracture of the cribriform plate, right? In case of the cranial injury, the fracture of the anterior skull base may be accompanied by a CSF leakage, because sharp broken bones may cut the dura, so that we will observe the CSF rhinorrhea. Right? Rhinorrhea is a leakage of the CSF through the nose. Now, unilateral damage of olfactory pathway causes abolition of smell sense. We call it anosmia, ipsilateral to the damage, simply because the pathway is not crossed. Now, the lesions affecting the lateral olfactory area may cause uncinate fits, which are a kind of epileptic seizures. And these are the seizures or the attacks of imaginary disagreeable odor with involuntary movements of the lips and tongue. So please remember that uncinate fits when someone, for example, smells a disagreeable odor suddenly, and nobody else can confirm it. This may be an uncinate fits, which results from the lesion affecting the lateral olfactory area within the temporal lobe. So please remember that, because this may be of a clinical significance. Okay, I think that would be all for these specific pathways. Thank you very much for your attention. In one of next classes, we will talk more about the pathways, so that you will have an opportunity to look at all these structures in the cross sections again, in the whole brains again, and please talk to the teachers about the course and the sites where all the pathways change the site and decussate. I would like to all the students that you know the beginning of the pathway, the end of the pathway, and the site where it changes the site, because it's extremely important for the clinical investigation in the future. Thank you very much for your attention, and I see you in the next topic. Thank you.
Thank you.
Thank you.
Bye.